My name is Dr. Phumzile. I am the Chief Executive Officer of the South African National AIDS Council, and I'm going to be your chairperson for this session. I'd just like to check whether the speakers are in the room. I've got Dr. Bernard Koomson. Hi, Dr. Bernard, how are you? And then it's Mr. Ndhlovu. Ndhlovu from Mpumalanga. That is a South African. I don't know if I'll be able to jump in for him like I jumped in for my principal yesterday. And then Dr. Babatunde. Welcome. Dr. Bernard Koomson. Dr. Bernard, please come to the floor. Round of applause, please. I can't remember which session I was in yesterday, but the person who was chairing said they are a Toastmaster. And at Toastmasters, you clap until the person sits down. So let's see if you are able to do that for Dr. Babatunde. Dr. Babatunde, let's see if they clap for you all the way. All right, so when Ndhlovu comes, Tshepo will join us. You've done well. So when Ndhlovu comes, he will join us on stage. Ladies and gentlemen, once again, welcome to our session. The session is called Behavioral Science, Collaboration, Politics, Politics and HIV Management, Stigma. And it's an abstract-driven session. So you are going to hear sessions from Dr. Babatunde, Dr. Koomson, as well as from Mr. Ndhlovu. I think behavioral issues are obviously one of the only ways that we are going to get to treat how we will never get to treat ourselves out of the epidemic. The thing that needs to change is the behavior side. Now, one of the abstracts I have here speaks to a very interesting development lately. We are all aware of the beauty and the value of artificial intelligence and new technologies. I'm a mother of two AGYWs. One is 16, one is 23. So they are smack in the middle of the 15 to 24. And they live in their phones or on their phones. So the only way that we can certainly influence behavior is by getting to them through methods that appeal to them. So I'm certainly looking forward to learning. And we heard yesterday about the importance of investing in prevention. And if I can give the South African scenario, let's say we've got 63 million people. 8 are living with HIV. And if we can just get the 55 million that are not living with HIV to stay HIV negative, that will take us well on the path to ending AIDS. Right, and then the session also goes on to collaborations. Collaborations is partnerships, it's coordination, it's the ability to understand that together we can go further than we can ever go alone. Now, I'm the director of a NAC, and the South African NAC sits in the office of the Deputy President. And we make sure that government, private sector, the development partners, as well as civil society, all pull in one direction in terms of implementing one national strategic plan. But we know that for our donors, the interests might not be those of the country. We know that for the private sector, they might have interests that say, what's in it for me? So we really need to redefine the power of collaboration, the power of country ownership, country leadership, and that speaks primarily to the Lusaka agenda and how we also get our global health initiatives to align with our country systems and the likes of Global Fund, for instance, not to be utilizing, by example, their own auditors when we've got supreme audit institutions that are respected in country, because that is money that could be utilized for program purposes. So when you talk about alignment between Gavi, GFF, Global Fund, when you look at the financial year, for instance, for South Africa, it ends at the end of March. But my PEPFAR year used to end in September. The Global Fund year ends somewhere else. The Gavi year ends somewhere else. Then you spend all your time writing reports. When do we get to do the work? So can we collaborate and align? And that is what the Lusaka agenda is about. Clap for the MC, guys. Don't be afraid. Don't be afraid. And then we are also going to talk about politics and HIV management, stigma. South Africa has just released the Stigma Index 2.0, driven by the Human Sciences Research Council. And it was released at plenary last week, Friday. And part of what we found is that people living with HIV are starting to be comfortable to disclose to their families and friends. But what remains very high is internal stigma. So what actually works against your self-worth, your self-confidence, and even your ability to want to hang around with friends or to go to occasions. And we still need to deal with stigma when you look at the high levels of advanced HIV disease that we have. People are not coming to facilities, and it might not only be for lack of access. Stigma is a big driver. So we are going to have a discussion today, and I'm hoping it's going to be exciting. And first up, we are going to hear from Dr. Babatunde, and just briefly, Dr. Babatunde is a medical doctor. He is a digital health innovator and a researcher, and he has a passion for improving the health and well-being of African communities. He is a One Young World ambassador and a recipient of the Diana Award. Please clap your hands. Dr. Abdul is also a serial volunteer who has led several projects to expand access to HIV prevention services among young people, and he is also a global health researcher with 30+ publications in international peer-reviewed journals. His research interest includes HIV and AIDS, implementation science, digital health, universal health coverage, and he is a recent graduate of medicine and surgery from the University of Ibadan, Nigeria. Dr. Babatunde, over to you. Thank you.
Yeah, my name is Abdulhammed Babatunde, and I'm presenting the topic titled Promise, Policy and Practices, How Sub-Saharan African Countries Respond to the United States Funding Cuts on HIV, TB, and Malaria. As a form of introduction, on January 20, 2025, the United States paused all its funding to, especially for programs like PEPFAR and Global Funds, and this significantly impacted the HIV programs, including TB and malaria. This cut is projected to cause the death of about 500,000 children in sub-Saharan Africa yearly, and the UNAIDS estimated that in the next 5 years, it will cause about 6 million deaths if there is no action taken. Besides the funding cuts, there is socio-economic, political, and medical crisis associated with these funding cuts. People have lost their jobs and daily livelihood. Political leaders are under pressure to look for other funding sources, and medical facilities are significantly overwhelmed. We did a review that describes the responses of countries in sub-Saharan Africa to the US funding cuts on HIV programs. And the review shows the initial responses from January to April 2025. During the course of presentation, I'll be mentioning some other things that has happened after that. We did a narrative review of the UNAIDS database published in April 2025 on the impact of the funding cuts. The data reported by USAID, US government website, and the country's authorities like NACA and other government aid agencies. We conducted a thematic analysis and categorized this into 3 groups. First is the plans by governments and agencies, which are the promises. Second is the legislations and policies. And the third one is allocated funds and initiatives that have been launched, which are the practices. Firstly, there are, in this review, about 21 countries are part of our reviews that are included in African countries that has responded to the US funding cuts. First, the promises, which are the plans. Most governments in the sub-Saharan African countries are promised to sustain their HIV programs despite the funding cuts. Some of the most important promises. First is the constitution of technical working group and task forces by countries like Botswana, Lesotho, Malawi, and Namibia. Second is impact assessments of funding by Burundi, Cote d'Ivoire, and Tanzania. And some other countries also develop mitigation plans. In Angola, Burundi, Lesotho, Malawi, and Zambia also develop a sustainability and transition plan. The policies. First, the Zimbabwe government is aiming to explore other alternative sources like airtime taxation for earth financing. while Togo has included HIV as a chronic disease in order to incorporate it in their national insurance plan. Uganda also has done this similar thing since the funding cuts. Nigeria's legislation inaugurated the 8th TB and Malaria Technical Working Group to help in tackling the funding cuts challenges. And Sub-Saharan Africa, the South African Parliament has approved an additional budget for health with 5.9% annual increase on health and 33% on annual raise for HIV programs. Now, the most important part, the practices, which are the allocated funding and implementation initiatives. First, the DR Congo is mobilizing resources. The DR Congo is mobilizing resources for the National HIV Forum and has now mobilized $18 million to close the funding gaps. And also, Ghana established the Medical Trust Fund with inclusion of HIV in this trust fund to help in catering for the funding cuts. Most countries, some other countries have also allocated more funds through their Ministry of Health, with South Africa allocating $1.5 billion, and Nigeria allocating $3.3 million, Uganda $1.6 million, which has later increased over the time to $8.8 million. And Liberia has allocated $300,000, and Mali $200,000. Togo also doubled the state health budget to increase it to an equivalent of $9 million. Other countries have also made some other commitments since the review was done, like Kenya, which increased their budgets for distribution of commodities, of pepper commodities with $9 million and $60 million to procure more commodities. This is a table that summarizes some of the responses by the African countries. Now, the recommendations. First is the advocacy for domestic mobilization of funds. Since the Abuja Declaration, only 3 African countries have met up with the 15% health insurance plan. We need to advocate through the advocacy groups and researchers to ensure that our state governments are more dedicated to allocate more funds to health generally and also have a specific proportion for HIV programs. Second is diversification of funding. First, we can explore some other funding sources like sector-specific taxes by taxing some sectors like aviation, telecommunication, also earmarked levies. This has been done in some countries like Zimbabwe through their AIDS levy program. And we can earmark some products like sugary items, alcohol. This has been recommended by WHO in order to raise funds in health. Third is HIV dedicated funds. We can encourage the private sector, philanthropists, religious organizations to donate to the national pulse and have a specific trust fund for HIV/AIDS. Other sources that we can explore is the public reinvestment, such as we see in Nigeria during the SUB program, whereby the excesses that were cut from the fuel subsidy was directed into HIV programs. Next is a more sustainable plan, which is integration of HIV into the healthcare system. We need to end HIV as a vertical program and integrate it to the healthcare system, such as prioritizing it as being part of the primary health care and also including it in the health insurance, national health insurance and social health insurance. This has been done in Rwanda, and some other countries are also implementing similar things like Kenya and some states in Nigeria, whereby people can access HIV programs using their health insurance. Next is investments in research and development. Over the years, African countries spend only 0.5% of their GDP on R&D, which is lower than the global average of 2.2% of GDP. We need to invest more in R&D and promote innovation. Local manufacturing of antiretroviral drugs and diagnostics, this cannot be overemphasized. We have made some progress in the last few years, whereby WHO has certified some pharmaceutical companies in Kenya, Nigeria, Uganda to manufacture ARVs and other commodities. The success in Kenya, whereby the products were actually got sent to Mozambique, is a very good progress, and we need to have more of that. There needs to be effective monitoring and evaluation plan, a standardized method to analyze the effectiveness of these sustainable health financing policies that we're implementing in Africa. Conclusion, while some countries have showed practical efforts, most countries still need, while some countries have shown practical efforts, government of many countries are still planning and promising. There's need for more countries to facilitate innovative funding sources and enhance domestic resource mobilization to sustain existing HIV programs in sub-Saharan Africa. Before I end, I need to remind us Every second that passes without sustained funding is a life we cannot afford to lose. Are we going to keep waiting for help? Let us act now while there is still time on the clock. Thank you very much. I would like to acknowledge Dr. Joseph Toka and University of North Carolina for giving me a travel scholarship to attend this program, and my co-collaborators. Thank you very much.
If Tshepo Ndhlovu has arrived. Tshepo Ndhlovu, not yet here. All right, so thank you so much, Dr. Babatunde. Dr. Babatunde really touched on the issue of the shocks that we've all been talking about. I think every speaker at the conference, when they start, they say, we meet at a very difficult time. We meet at a shocking time in history when funding has been pulled back. And it's really about innovative financing, but it's also about the fact that nobody is coming to save us as Africa. The need for domestic investment and domestic financing is quite important. And it's also about collaboration. He spoke to partnerships in terms of religious institutions, the private sector, and when we get into the discussion after the next presentation, we can explore that further. So thank you so much, Dr. Babatunde. Our next speaker is Dr. Bernard Koomson. Dr. Koomson is a research fellow at the Center for Interdisciplinary Methodologies at the University of Warwick in the UK. His current research explores the future of human rights and youth participation in the digital age through transnational collaborative approaches with researchers and civil society groups. He is particularly interested in how power, social and economic inequalities shape access and governance within the digital community for young adult key populations, and the extent to which these inequalities affect the uptake of their fundamental human rights, particularly the right to health. Through a rights-based epistemological lens. Oh, Dr. Koomson. Bantu education. He employs a particularly participatory research approach, and from the University of Warwick to present his paper entitled Safe Online, Experiences of Young Adult Key Populations Seeking Information Online. Dr. Koomson, thank you. Round of applause, please. What a big word, hey?
Apologies for that jargon. Thank you very much. Good afternoon to everyone. A title of my presentation this afternoon will be Safe Online, Experiences of Young Adult Key Populations Seeking Health Information. It's not yet up, but nonetheless, I think I'll go ahead. So this is part of a 4-country study that the Digital Health and Rights Projects at the Center for Interdisciplinary Methodologies, Warwick, University of Warwick, UK, has been conducting in the past 2.5 years. And I want to share snippet or aspect of the findings on online experiences of young adult key population. We build on the rapid transformation of digitalization in health, particularly how this has coincided with the spread of internet and growing youth population, as I would show. We have seen that in the light of this, many young adults have also found solace online, building communities, using these digital platforms to access information on health, a variety of issues that they would otherwise, because of discrimination challenges that they face within their communities, within the community. Nonetheless, much as these technologies have huge prospects and are mostly simple to join, they come with challenges, and this is what my paper seeks to explore, looking at the case of Ghana, Kenya, and Vietnam. You could see the rise in youth population, quite unfortunate we don't see the slide, in lower and middle income countries has also been accompanied by a widespread of internet across board. And we understand that young adults are the major key stakeholders in terms of patronizing internet usage as we have in the world. So the DHRP, or Digital Health and Rights Project, which basically research, advocacy, can we go to the, I think the fourth slide or so? Third, go ahead. Forward. No, come back, please. Come back. Yes, this is where we are. Thank you very much. The DHRP, Digital Health and Rights Project, which actually holds this grant and been conducting this research, 4 countries, made up of 10 organizations in 10 countries, highly collaborative approach, mostly using participatory techniques from top to bottom. We have the principal investigator and researchers at the University of Warwick, and joining us as part of a consortium of research organizations, Ghana Network of Persons Living with HIV, NAPLAS Ghana, Kenya Legal Ethical Issues Network on HIV and AIDS, KALIN, which had a session earlier in the morning, Universidad de los Andes in Colombia, Vietnam National Network of People Living with HIV. You have other collaborators, as you would see, Restless Development, Stop AIDS UK, and Privacy International. Next slide, please. So as I said, we employed participatory action research across, and participatory action research engages participants of the study from its very design to the conclusion or writing of the findings, and in our case, even spearheading advocacy at the national level. As you can see, it's co-designed. And a very key feature of this is community advisory teams, who are representatives of the very communities that we engage in this study, talking about young adults living with HIV, members of the LGBTQI community, and so on and so forth. We have all of them represented within our community advisory teams. Research strategy was basically qualitative, doing focus groups and in-depth interviews in rural, urban, peri-urban areas. In the case of this study, I limit myself to some snippets from Kenya, Ghana, and Vietnam, using snowballing 4 languages in all, English, and Swahili, and Twi, and almost 1,500 pages of transcript translated into English. Could see that we had a very diverse population. Unfortunately, we may not be able to see, but these are the ways that they chose to be identified, as we have presented. 7 gender identities as self-reported, so don't look at the book. These are what the participant told us in terms of being male, female, non-binary, sexual minority, transgender, and we had multiple data from Ghana, Accra, Kumasi, Tamale, Nairobi, Migori, Kitui, and Mombasa, Hanoi, and Ho Chi Minh City. Top concerns across all these 3 countries, including stigma, fear of their privacy, and also fear of being outed online. As you can see, most of them referenced browse search queries, text messages, social media likes, could out a person to a community, especially those living with HIV, where if they search out information, especially for those that didn't have phones, could be traced to their status, and which was very, very unpleasant. Fears of hacks, leaks, digital health companies sharing their data with third parties was also a concern, and fear of vigilantism for some of the persons who identify with the LGBTQI community. And all of these, we are saying, led to them being reluctant to engage frequently online. 3/4 of our study participants also described technology-facilitated abuse, and abuse increasingly normalized within some of these communities, mostly affecting women, men, trans people, members of the LGBTQI community. Types of abuse included cyberbullying on social media, fraud, hacking, non-consensual porn, stalking, blackmail, and falsified images, especially of commercial sex workers. Abuse, we also found, moved from online to offline spaces where serious physical violence were reported by some sexual minorities in Ghana and to a lesser extent Kenya as well, because of their identities being outed online. They were traced and some of them were even assaulted. And we are saying that all of these affect this young adult key population, how they would want to engage and use these digital platforms to search out health information. Unfortunately, most of them could not gain access to remedy, even though they had been abused. Some had to go to the police, and sometimes the police didn't really know how to handle that, because there was no straight process through which they could go to address abuse online, and would just turn them away, and sometimes even aggravate the abuse and get them traumatized. So as we have, I can't just go to the police station and say this content creator has abused me. Where are they going to find him? That's one of the quotes from a participant in Tamale. Conclusions, Stigma. We found that the risk of being digitally outed and abused can be devastating, leading from stigma to abuse, leading to the breach in rights in privacy, and key populations, actually young adult key populations, deciding not to engage or reducing the level of engaging online. We believe that this must change, and the public must be informed of their rights, and how also there should be straight, very unambiguous processes through which they would be able to find redress each time they are abused. Technology-facilitated abuse still on the rise, affecting mostly trans people, young people living with HIV, sex workers, HIV activists, especially those who try to share information about HIV are all the more even abused. We call for a survivor-centered approach, strengthen laws, prevent and respond to technology-facilitated abuse. Design justice need to uphold. We ask that these digital platforms need to uphold design justice for marginalized population. There should not be a wholesale approach to this. How do we make sure this fits these populations who have use of them, whose best prospects of living privately and safely may be online, especially for those living in countries where day in and day out, draconian laws are coming up to breach on their rights. It's really, really important that we make life online safe for them, because that may be the best option we may have for now. Yet, young adults remain resilient, calling for more protection, meaningful participation in digital governance, and also in digital literacy on how to stay safe online and navigate freely and minimize level of abuse. Thank you very much.
That digital health can transform healthcare, but only if it's safe, if it's equitable, and if it's ethical. So we are really grateful for that. But as we embrace it, I think what I heard is that there are some controversies that do come with it. Our data is now more vulnerable than ever. I mean, I work for the South African National AIDS Council. I think by virtue of having South African in our name, it just makes us prone to hackers. It just makes us prone to hackers. I think also the lack of clear regulations do leave us somehow exposed. I think as we talk a bit more, when it comes to AI, we do need to talk a bit about clinical governance of AI, who takes responsibility for the errors and the mistakes, but how do we not lose the fact that in many instances, when implementation moves fast, it can overtake policy. So if we get stuck on governance, we might not get the best benefit out of artificial intelligence and digital health platforms. So it's that fine balancing act. And I can see a few key people in the audience that I'm going to pick on to share some examples as I talk if we run out of questions. But I'll open the floor, ladies and gentlemen, to you. We've had two great presentations, one related to the funding cuts. I'm actually disappointed that our session is supposed to end at 13:45. So we've got about 10 minutes, and I did say, I am known for my timekeeping skills, so I will not delay. We've heard about the PEPFAR cuts, we've heard about the opportunities, and maybe let's also start thinking about when we speak to philanthropists, when we speak to the private sector, what are we asking for? And how do we want to monitor that? So we've got Dr. Babatunde, and then we've just had the digital health presentation. Colleagues at the back, can I check if there's a roving mic for questions? Do we have one? There's a gentleman who's 17 there, and he's pointing me here. I'm 51. Please come. Thank you, Nana. Thanks. Please run with the mic. My knees will give in just now. All right, colleagues, may I have a show of hands for any comments, questions, clarities, anything? I see a hand there. I see number 2. I'll take 5 at a time. So just remember your numbers. Where was the first one? 1, 2, 3, 4, 5. All right, so we'll go in that order.
The presenters and the moderator. My name is Barbara Kemigisa from Uganda. First, I want to thank the previous presenter for engaging the lived experience right from the beginning and throughout the research. And I really hope we can also see them during the presentation of your research at some point. It's really important. I've learned that because I've been funded by Mental Health Data Prize, which engaged me as a lead lived experience in their research on mental health, and I'm leading a research program called Group Support Psychotherapy among young people living with HIV in Hoima City in Uganda. And I really look at, before we become HIV positive, we are still going to face the challenges that everybody else face. We are going to be single young people who are dealing with relationships. We are going to be coming from families where our parents are having domestic violence. We are maybe we're ever chased out of school because we don't have school fees. All these issues are really stressing us. So we come from just stigma, denial, and all that affect people living with HIV, and we end up being depressed. And these are things we don't really look at in the mental health facilities, or we are looking at counselors. But you go to a counselor, you look at the counselor and you're like, am I really going to talk to this person about my issue? You end up keeping it because you can't talk to them. But also there is a queue outside. You feel you're not going to have all the time to talk about your issue. So that's why we opted for the group support psychotherapy. I would like to talk about domestic funding, and I'll give an example. I work with Barbara Kemigisa Foundation, and I'm Barbara Kemigisa. And the funder we had would give us the quarterly money that could be salary for a month for one of their staff. And yet they expect us to use this money to implement for 3 months, and we are dealing with people who are walking 20 kilometers from home to the facility. But again, my biggest issue is when you look at the domestic funding, these governments are collecting tax from people like us. Me as the executive director, my organization does not give me salary because I have employed two people who the funders are actually giving salary. But now the Revenue Authority is saying you cannot be the executive director and the organization is in your name and you don't pay tax. So I'm under that pressure. But when you look at the organization funding us, they buy new Land Cruisers every year. They have SC offices. Their staff get 7-figure salary. When they're going for meetings, they go in a posh hotel and they get per diems. But what happens to us? So I'm looking at, instead of us living with HIV, that money, all the funding we are saying has been cut, we only get ARVs from all that money, and that's the fact. So me as a person living with HIV, trust me, I'm saying thank God they cut the funding, because after all, I've not been getting the money that they say they are giving us. So I'm saying, why can't you create funding opportunities that are actually providing sustainability plans for the person living with HIV? The example is, I work in small groups of peer, I create peer support groups for our young people, and out of these, we've been able to create these tiny bracelets. They're out of paper. But I, the executive director, I go hawking these paper beads and sell them. We've been able to take some of our young people back to school. We are creating the first youth-friendly community center in our village. We are able to have some monthly pocket money for our young people instead of them going out there doing nothing. And we are doing a lot of community service to change community perspective on who a young person living with HIV is. But these young people are also able to go to hospital and pick their medication. They have improved in their adherence. They are getting non-suppressed and their well-being is better. So I feel if we as people living with HIV are given these funds so that we can start small projects for self-sustainability, it will be much better than giving this money to those big organizations that are going to take all that money.
Thank you, Barbara. Thank you so much. Please clap for Barbara. I think she's touched.
The bracelets are here for sale. Thank you so much.
Okay, so Barbara has touched on multiple issues. She's touched on the importance of funding communities. She's touched on the models for social contracting and how we actually need to be negotiating. I think she's even informing the MOU processes that are happening now with the United States government and how those should be going in terms of dual accountability. So thank you so much, Barbara. Well done. Colleagues, may I please ask my next speakers to be brief. Barbara, you were the first one, so I allowed it, and you are from Uganda, and you are young, and so I let it. But I'm going to allow my next questions to be quite brief, please.
Thank you, Chair.
Please stand up and introduce yourself. Thank you.
You don't understand that age is dealing with us here, and our needs are no longer the same since we're disclosing. Chair, I'll try not to preamble, but don't feel Mjalim. I'm from Shout It Now in South Africa. Two questions really for the speakers, and this is a very important conversation. Firstly, Dr. Babatunde, you highlighted and you summarized the responses, and I'm actually quite wondering if you did actually look at which country has the best response. So that's a controversial question. We can take it offline. And also just to understand, just on the same vein, what accountability and monitoring mechanisms are actually needed to track whether these promises that have been made, and albeit some of them are being slow, and these policy commitments that are made by countries actually result in measurable program continuity and health outcomes for people living with HIV, TB, as well as malaria. Secondly, again, I won't preamble, but we use a lot of digital tools, including AI. Dr. Koomson, is that the same? Just in terms of our work and being able to reach young people. And my question, and some of it is really laden it's in between the lines. What role should policymakers take, developers, as well as community-led organization, each play in ensuring that AI and other digital tools are upholding the digital rights, human rights, protect privacy, as well as actively reduce inequalities for young people seeking care online, because that's a question we're actually grappling with as well. Thank you.
Thank you so much. Number 3, where was the third question? Yeah, please go ahead. Thank you.
Thank you so much, Doctor. I am Nelisiwe Zuma Mzizi from South Africa in KZN. My first question goes to the young Dr. Babatunde, appreciating the research as well as the recommendations. However, I've got just one question, which then seeks to understand if there was any personal analysis done in terms of the policy changes across the countries, considering the environmental changes and the financial situations of each country and the population size. And then again, coming to you, Professor, thank you for the study that you have made. The question is, we are talking about the mind challenges of young people. You have mentioned the 3, which are psychological, bringing a psychological impact, as well as the upbringing of a community. The question is that I'm referring you to is that when you were doing the research, did you consider the impact analysis of the psychosocial support or the psychosocial impact that is happening between the age gap, as we are focusing on the new age group that are more into artificial intelligence, are more into digitization and digitalization, while leaving the other community which is still left behind. And the other one, have you also considered the social behavioral changes, effects that is happening across all the key population and the age group, and what impact study have you seen in noticing? Because we have had the funding, but what impact have we had by providing our resources across? Thank you.
Thank you so much. I promise we will not take longer than 5 minutes, if you can just bear with me. But I think when behavioral scientists speak, you can hear the language, it comes through. So we'll take 2 more questions, and then we'll allow you just to summarize, and then we'll close the session. Thank you.
Thank you very much. My name is Abdulhammed Ibrahim from the PL-HIV network in Nigeria. My question just goes to Dr. Babatunde. Well done, good statistic. I just want to know if you could provide feedback in terms of all the resources that the African leaders are able to put on the table as part of their contribution to mitigate the funding cut, so that we could be able to learn about how our government are really investing, just going beyond pronouncing amount of money, but releasing those resources to go for what they are meant for is critical for us. Thank you.
Thank you so much. Last question at the back. Thank you very much. So I hope you are noting your questions. I'll get back to you, and then we'll close. Thanks.
Thank you so much. Thank you so much, moderator. My name is Claire Nampenja. I work for the International Community of Women Living with HIV Eastern Africa, and I am from Uganda. To our panelists, thank you so much. That was really great work you did. So my questions are just two. On cyberbullying, especially for the sexual minorities. It was in Ghana, right? So I wanted to understand, after those young people being abused, psychologically, of course, because sometimes you're abused on social media, but there is no help, like no one can come to rescue you. So I was asking what was done to ensure that, I heard you saying that police did not even help, like no one came up for them. So what was done to ensure that these people get justice at some point, or they do not shy away about what they're supposed to speak about? Because, you know, in this era, we are looking more at utilizing social media platforms to ensure that messages go on and young people are able to access them. So what was done to ensure that they continue to do the work? And for the funding cuts, I think it was Dr. Babatunde. I wanted to understand what has been done. We have seen in Uganda a lot of drop-in centers for key populations were closed. And also we had community areas where people could go and access their treatment. The pharmacy models are not now working for people living with HIV. And also the CDDPs are not working. So I wanted to understand, how is it done in your country to ensure that despite the funding cuts, but people are still accessing the services, to ensure that we do not get services only at the facilities where you come and it's all full. We do not know what is happening at the facilities and in the community. So what has been done to ensure that people, especially young women living with HIV, are accessing health care right from the facility and the community? Thank you so much.
Thank you so much. All right, we'll start with you, Doc.
Thank you very much. I will go to the first one, which has to do with the role of government, civil societies, communities in development of AI digital tools and how that promotes digital rights. So what I would say is that there's a growing movement of actually called participatory AI, where the argument is that communities or beneficiaries of any AI tool must, from the very startup, be involved in the development of these tools, especially the way the algorithms are trained, what extent do these developers go to ensuring that there is a fair representation of these communities during algorithm training, so that in the end you don't have some of these communities left out or discriminated against when it is actually deployed. So I think the charge that I would give all of us at the forefront of promoting digital rights, digital technologies, is to make this a very key aspect of our advocacy in joining the participatory design justice AI form of development, in ensuring that whichever communities we represent are actually factored into these developments. Because if we don't, once these are rolled out, there's nothing you can do about it unless they are revised. So that's what I'll say. Yeah, and then the other one, I think is 2-in-1, psychosocial supports, what we had from, so as part of our research, we did envisage this. So we had specialized centers that provide these support to the youth. So in our debriefs, if we did find out that there are still people who are traumatized, we would link them to that. As for issues on police law, it goes beyond our research. So once again, we come back to advocacy. What are these laws that we have in our countries? How are we represented in these laws in terms of our take in them? And how are we not making sure we only sit down until we get a situation like this and we find out that actually the law does not even recognize that we exist and our needs are very important. So all of these must also come up in our advocacy, especially the digital stuff, and for us to be able to address these issues. As for the third question, it was beyond the remit of our study, so maybe if you want us to talk about that, she's there. Yeah, thanks.
Thank you very much. It's very important to prioritize social enterprise in solving problems rather than just depending on funding, and it's a very good initiative to have the model of selling handbands to sustain the project. I think that's a very good idea, and it's something that should be emulated in other countries. And about the country with the best response, I think that was the other question. I think that was just, by the way, we don't have any measurement to say which countries having the best response. Then it's very important to measure the promises. Like I said, most of the countries are still at the stage of promising and planning. A lot of political will need to be into the process of passing through the legislation, and it's very important. Probably in the next 1 year, we'll be able to say specifically how this project, how the sustainability of program has gone, and I believe it's still early. And in designing projects that are sustaining health financing in HIV, from the early stage, we need to start thinking about how do we measure the impact of this project. Recently, after this study, we conducted a scoping review on the implemented project on financing HIV, and we found out that there's only 3 studies that we found actually talk about the impact of the sustainability of the HIV financing project that has been done. So we need to look at measuring the impact, not just having the program, by also supporting with scientific evidence. Okay, so regarding the African governments, the resources they are pulling together, I don't have any report yet about like African governments joining hands together as African Union, but there have been intentions and a lot of efforts to ensure, especially the manufacturing of ARVs in Africa. Africa CDC has been leading that with trying with the strategic plan for 2026 to 2031, and that's about that. And for Nigeria, how the project has been sustainable compared to Uganda. In Nigeria, although there has been like reduction, but the HIV programs are still running based on the support from the government, and some states have also included HIV in their health insurance, like Lagos State government and some other governments in Nigeria. So through that, it has been sustainable, although like there's reduction in access to preventive care, especially. Thank you.
Thank you so much, ladies and gentlemen. So in closing, I'm really going to say we've heard that potential partnerships, collaboration with our philanthropists, private sector, government. I really think when we have those discussions, we should be talking about what are we asking for? We are asking for action, we are asking for technical assistance, and we're asking for money, right? But not just from outsiders, from our governments as well. We need our governments to recognize, for instance, that Africa has got what Africa needs, and the model of technical assistance needs to change. We've got African research institutes that can actually provide technical assistance at half the cost of an international university. So that would really change the way we look at how we reach out for help when we start to look within. So in terms of action, very true. Abuja Declaration, all these declarations, all of us are at about 8-9%, which is where most European countries are. Very few countries have reached the 15%. But the truth of the matter is, when it comes to external funding, are we applying dual accountability mechanisms? Or are we allowing donors to come into countries, implement parallel systems, and paralyze the systems that we have? So when we have those discussions, they should be about invest in resilient and sustainable health systems so that moving forward, we are able to carry it beyond the shocks of the current. And then in conclusion, Dr. Koomson really argues that digital platforms shouldn't be treated as isolated living spaces where the rights of young people are upheld, but they should be protected and they should be accounted when infringed upon. So there is no doubt that digital technology has got a huge role to play in terms of HIV prevention. And I'm going to end just on the issue of lenacapavir because we are introducing this as a prevention mechanism. We are all aware of the controversies related to LEN, the pricing, the cost, the sustainability, but there is no doubt that we need our communities to be involved. We can't sit at the top table and decide who gets lenacapavir. We need to go to communities, have the discussions with them. What are the pros and the cons? And let them help us to decide who is best. The modeling will tell us, go for key pops, pregnant breastfeeding women, etc. But the bottom line is we need communities in order to drive a sustainable service delivery model. And in order for us to be sustainable from a financial digital health perspective, Africa needs to be allowed to produce the drugs that Africa depends upon. You've been a great audience. I love you all very much. Bye-bye. Thank you. Thank you. Thank you.